Hi, this is Jean from Sonovault. This video will talk about the basics of interventricular septal changes. This video is part of a series of videos on cardiac cavity structural changes. At the end of this video, you will be able to understand the basic approach to interventricular septal changes, to differentiate pressure overload and volume overload, and to understand how the physiology impacts the changes. We will quickly highlight some basic concepts related to the acquisition of proper interventricular septal assessment. I want to refer you to a very interesting article to understand all the septal shifts and an approach to differentiating them. It is definitely worth a read if you have the time, but it covers way more than we will go over in this lecture. We will cover the basics of the most important elements related to interventricular assessment. There are a myriad of other causes of more septal changes, which will be covered in a different video. These are the three main views used for assessment of interventricular septal motion: the parasternal long axis view, the parasternal short axis view, and the apical four-chamber view. All the other views can be useful in specific applications, but are not necessary for basic assessment. You will also optimally need the EKG leads on your machine. This is essential for proper assessment of the timings of the septum. If this is unavailable, use the valve opening and closing to assess systole and diastole, which are the main markers that you need. I also recommend freezing a loop and slowing it down and carefully noting when the septum changes direction. People advocate the use of M mode, and one of the difficulties with the article listed above is that it relies a lot on M mode. This is a very helpful mode if you're experienced with it. For most users, however, the subtle changes will be hard to be confident about. Our eyes are usually better acquainted to 2D images and motion due to simple exposure to seeing cases. We are also in general just better at recognizing movement patterns than we are at fixed images. In summary, M mode is not essential for most basic gross applications, but it is quite useful and essential for things such as constriction and restriction, which is the lower image on this slide. I suggest using it for timing in some of the more obvious applications to confirm your findings. The last thing that people often say that you need the Doppler. And the Doppler is extremely useful in specific applications of septal abnormalities. It remains important to know that if there are obvious important septal changes, especially prolonged ones, the Doppler use becomes less critical to the diagnosis. The main use is to determine and distinguish the presence of constriction and restriction. This is obviously an advanced expertise. We'll start with some normal physiology and visual findings of the normal septal structure and motion. The key feature to understand of normal physiology of septal changes is that LV pressure throughout systole and diastole almost always exceeds the RV pressure. In the animation seen above, LVDP refers to LV diastolic pressure and always exceeds RV diastolic pressure, and LVSP refers to LV systolic pressure and always exceeds RV systolic pressure. As such, the septum should always remain in its natural configuration and maintain the LV bullet shape. This is optimal for myocardial contraction. This is a normal interventricular septum. Notice that the contraction is simultaneous with the outer walls. The septum remains rounded, with the convex portion towards the RV in the parasternal short axis view. This maintains the bullet shape of the LV. In the apical four-chamber view, you notice that this remains true, and there is no motion of the septum that is discordant or in the other direction from the outer walls during systole. As we discussed, M mode can be used for this application. I really want to stress that M mode is not essential for most applications of septal assessment. The subtle changes that it is most useful for are not for basic usage. They are mostly for assessments such as constriction and restriction. Most of the time, simple 2D structural changes in the parasternal short axis view are sufficient. Nevertheless, the way to perform an M mode in this instance is to do an M mode through the parasternal long axis view, going through the RVOT, LV cavity, and capturing the mitral leaflet throughout systole and diastole. M mode for septal assessment has to be performed this view because the septum is then parallel to the beam, ensuring an adequate view of all relevant cavities. Doing an M mode in a parasternal short axis view is possible, but the angulation is often suboptimal to obtain all cardiac cavities and a good septal alignment. We will go over this quickly to give you an overview of the features in case you're interested in looking at this further. M mode is a single line of ultrasound over time. In the parasternal long axis view, the RVOT free wall is on top, followed lower down by the RV cavity, the septum, the LV cavity, and the LV inferior wall. Seeing all the structures is important because you need to time the relative appropriately directed movements of each of those components for M mode to be useful. This essentially allows you to deconstruct the pattern you will learn to recognize by 2D in this talk. I'd like to reassure everyone here that I'm not trying to scare anybody with complex graphs. This graph is simply for people who are interested in understanding exactly the physiology of how the septal changes happen. These will be helpful when you look at more advanced features in other video series. For most users, focused on the RV ejection time and LV ejection time. As we said earlier, the LV pressure almost always exceeds the RV pressure. There's a small window during cardiac contraction in which the RV pressure exceeds LV pressure, which usually amounts to so little it is not noticed. Physiologically, this is the time during which the RV starts ejecting earlier and then relaxes later than the LV because it pumps against a lower pressure. It is thus able and allowed to contract for a longer duration before the pressure it generates falls below the pulmonary pressures. In summary, the RV ejection time exceeds the LV ejection time for a short duration, and in that small space, the RV pressure can exceed the LV pressure. Changes in intrathoracic pressure will affect predominantly the RV rather than the LV. As you can see here, the RV ejection time is the only one which significantly changes in a normal patient. A normal non-mechanically ventilated inspiration will decrease the intrathoracic pressure, leading to a reduction in RV afterload and an increase in RV preload. The LV preload is relatively unchanged as the intrathoracic negative pressure is transmitted to the pericardium. As such, there is a prolonged RV ejection, even more so, while the LV ejection remains essentially unchanged. Of course, these are obviously exaggerated for the purpose of showing clear difference and generally leads to minimal RV and LV changes in normal individuals. In summary, anything changing the return or ejection of volume from the RV and LV can impact the pressure differential between the cardiac cavities. It really is easier to think about it from the RV perspective than the LV one. There are two main first steps to be very careful about before even trying to interpret the interventricular septal changes. First is having a standardized view. As you can imagine, we are often looking at the shape of the septum to decide what is going on between the two cavities. Hence, if the view is non-standardized, the septum may appear abnormal, even if it is not. This is an example of a foreshortened parasternal short axis view. You can see that the septum appears flat, but this is actually an illusion. The second thing is to always look at your EKG first. The presence of a left bundle branch block will very often lead to a septal shift that is very characteristic. It also makes interpretation of further shifts as well as myocardial thickening or LVEF pretty difficult. Pay close attention to this clip as it is the typical appearance of a more obvious left bundle branch block induced paradoxical septal shift. This is a bit more of a loaded graph and are there for those who really want to understand the timings. Focus on the bottom part. Essentially, in this instance, there is a delayed LV contraction and relaxation compared to the RV. This shifts the whole pressure differential in multiple directions during the cardiac cycle. Essentially, you end up with a small shift towards the LV, a shift back to normal, then an exaggerated shift towards the RV. It looks a lot like a fluttering. M mode gives you a very good appreciation of this. Here, what you see following the arrows is that the septum appears to be contracting before the LV inferior wall contracts in the picture on the right. Contrast it with the baseline picture and you will clearly see that the septum and LV inferior wall are contracting at the same time towards the middle. Obviously, anything that causes a left bundle branch block will lead to this, including ventricular pacing, as seen here. Notice that this is quite similar to a left bundle branch block. There are a lot of ways to classify the septal changes for ease of identification. This is one of many ways. The first step for me is to identify if the septal change is prolonged during the cardiac cycle. Prolonged in this case means having a septal abnormality that stays uninterrupted during a portion of the cardiac cycle. This may be a significant portion of systole or diastole. The first of those pathologies is RV volume overload, typical of isolated tricuspid regurgitation. In this animation, you initially see a callback to normal diastolic pressures, in which LV diastolic pressure exceeds RV diastolic pressure. In RV volume overload, this is not necessarily true due to massive filling of the RV. As such, the RV diastolic pressure can approximate or exceed the LV diastolic pressure, bowing the septum towards the LV. In systole, however, the strong LV will generate enough pressure to recoil the septum back in position. This is one of the typical findings that you will see in somebody with an RV volume overload, in which the septum is not entirely round during the entirety of the cardiac cycle. It flattens during the diastole and tends to recoil and become rounder during systole when the LV cavity is smallest. As a general rule of thumb, if septal flattening is not throughout the whole cardiac cycle, it is diastolic and related to some degree of volume overload. I would advise to really focus on the parasternal short axis views for this pathology, as the septum is hard to really get a good feel for in the other views generally used. These views are helpful for other reasons, just as RF morphology to distinguish the cause of the septal changes. M mode can also be used to validate these findings, as it makes systole and diastole appear simultaneously and thus may be easier to compare. You can pause the video to better look at this M mode tracing. The highlight here is that the septum is flat in diastole and bounces back up in systole. This is the reverse of the normal dipping of the septum during systole. RV pressure overload is the second pathology that creates a prolonged septal abnormality. There are obviously multiple causes and a progression of the pathology over time, but in the more obvious stages, a pressure overloaded RV has a persistently flattened interventricular septum. The key is that it is worse during systole. Again, the first part of this animation shows a normal LV and RV diastolic pressures. In RV pressure overload during diastole, the RV diastolic pressure is elevated, contributing to some shift of the septum towards the LV. Systole exacerbates the problem because the RV systolic pressure overcomes the LV systolic pressure, furthering the septal shift towards the LV. This happens because the RV pumps against a high pressure, but also because the LV ends up underfilled and unable to mount a large pressure despite a normal contractile strength. This is an excellent example of this. The septum is always abnormal, but notice that as both cavities contract and become smaller, the septum bows even more down towards the LV. These are other examples of less obvious RV pressure overload changes. The right one seems to maintain a pretty persistent flattened D-shaped septum throughout systole and diastole, with the same component of increased D-shape during systole. The one on the left is a little bit less obvious and becomes rounder to some extent during diastole. In this particular instance, there's a parasternal long axis view and apical four-chamber view showing a very collapsed LV and very big RV. This obviously shows the septum in an abnormal position, and it can be useful to distinguish the cause of the septal changes. M mode here confirms those findings. Essentially, there is a persistently flat septum during the cardiac cycle. Importantly, remember that while it appears fixed in place during systole on the M mode, It is actually shifted during systole as the LV cavity decreases in size. Here, the yellow arrow represents septal flattering during systole, while the red arrow shows worsening during negative pressure inspiration. Notice that, except for what is likely a dropout after the red arrow, there is persistent septal flattering during diastole. An early finding of precapillary pulmonary hypertension causing RV pressure overload that is much more subtle is protodiastolic septal bowing. This is a simple single rapid shift of the interventricular septum towards the LV in early diastole with a quick movement back in position. The easiest way to think about this is to return to basics for this protodiastolic septal bowing. The RV contracts longer than the LV and thus relaxes a bit later. The higher pressure generated in this short segment is enough to displace the interventricular septum towards the LV for a moment when the LV is empty. Timings, however, remain relatively normal. Of course, remember that any of those changes will look worse with intrathoracic pressure changes, as they will impact both the pressures generated in the RV as well as the ejection and relaxation time. You will see shifts during respiration. These are also obvious on an arterial line usually. This leads us into septal shifts that do not have a persistent, prolonged abnormality throughout a large portion of the cardiac cycle. These tend to have multiple septal movements during the cardiac cycle, often even during a single phase, such as in diastole. This video will not go into important detail as this is more advanced, but it aims to give you some example of the other pathologies. Tamponade can cause septal shifts that are exacerbated by respiratory effort. In truth, these are often a finding that is difficult to properly determine as the heart is also somewhat moving in the pericardial sac. The real feature of importance are generally chamber collapse, usually the right atrium and then the right ventricle in typical cases. Constrictive pericarditis is what most echocardiographers call the bane of the echo consult. It usually is incredibly difficult to identify as the changes can be quite subtle. The telltale mark is a subtle septal shift. This series of images was a suspected constriction that remains unproven, but highlights this subtle septal shudder that you may notice. This is a way more obvious constriction pattern. There is a shudder of the septum back and forth rapidly, almost 4 times. This generally is a bit more prolonged and repeated than a left bundle branch block, but can resemble it. It is called the double wobble sign. The most impressive finding, however, is the sudden excessive septal shift, representing sudden halted filling during inspiration. You will see that the septum rapidly and excessively shifts from the RV towards the LV. This is typical constrictive pattern. Notice how strong the septum bounces back in the apical 4-chamber view? That is pretty obvious constrictive pericarditis. Of course, it is not always that evident. The main element that makes those changes more obvious with respiration in those 2 pathologies is pericardial constraint. With a fixed cardiac volume, any intrathoracic pressure changes that affect the RV loading inversely affects the LV loading. The LV ejection time thus changes, which is atypical for most other cardiac pathologies. As such, the septal shifts are thus exacerbated both in inspiration and expiration. This is the echocardiographic equivalent of a paradoxical pulse. Restriction, from a septal movement point of view, is relatively similar. In my experience, it may be a little bit less of a rapid and excessive movement. This is likely due to intrathoracic pressures being transmitted to the heart in contrast to tamponade and constriction. This is the same patient in apical 4-chamber view, and you can notice that the septum does have some shift, but is not as obvious or as important as the other pathologies. Severe mitral stenosis mimics RV volume and pressure overload, with predominance of volume pattern. There is a classic diastolic dip, as RV pressure can exceed LV pressure at that point when the LV is particularly empty. This is often hard to properly notice, but is a classic reported finding. Septal ischemia may also cause some changes in motion, but it is mostly through hypokinesis and akinesis. The septum will thus look abnormal, but it often appears to shift because it is being dragged by the other walls. Finally, the post-op cardiac surgery patient very commonly has interventricular septal changes in about 40 to 50% of patients. This sometimes appears to be even more frequent because of concomitant increased resistance in the pulmonary bed and septal ischemia that are also common post-operatively. This is not unique to on-pump cardiac surgery, and the off-pump cases may be related to simple pericardial opening and its consequences. The exact mechanism is unclear at this point, and it is postulated to be essentially any individual or combination of the previous elements. This is the end of this video related to interventricular septal changes. We would like to thank Sarah Blissett from the Western University in London, Ontario, for providing us with some clips of constriction and restriction. Feel free to contact us through our Twitter accounts with any question or comments at @DeschamPsJD or through the Sonovault channel.